If you wouldn't mind telling me a little bit about the recent NIH study involving evacuees from a number of years and generations.
Sure. Well, the big question that we sought to answer is whether a childhood exposure has mental health effects that carry across generations.
Tell me what you had looked at.
We conducted a study that was published in 2015 that asked the question about the mental health, the long-term mental health of the Finnish children who, during World War II, were evacuated to Sweden. This was a large-scale program that, during World War II, evacuated about upwards of 50,000 children to Swedish foster families to protect them from the bombings associated with the Soviet wars. Those children spent between 2 and 5 years with Swedish foster families, and then at the end of the war were brought back repatriated to their families. So in our earlier study, we asked the question, well, what is the mental health status of those former evacuees? And what we found was the evacuees had higher risks of being hospitalized for a psychiatric disorder, and that was primarily amongst the girls when they grew up. So there were the former evacuees, the women had higher rates of being hospitalized for a psychiatric disorder, and most strongly was for a mood disorder. And a mood disorder is depression, bipolar disorder. Those are all considered mood disorders.
Were researchers able to pinpoint or come up with any reasons why the rates were so much higher for these people, for these women who had been refugees and then brought back to their country?
We couldn't understand the mechanism in our study, but our findings are consistent with what we know about childhood exposures, like being separated from family and other types of adversities during childhood, which we know do have long-term effects on mental health.
Then you and your fellow researchers took it a step further?
Right. Exactly. So that was our earlier study, and what we've just done is to ask the question, well, what about the offspring of the former evacuees? And we thought that there might be some long-lasting effect across generations because of some emerging evidence in smaller studies which says that adversity might not only carry over within one's lifespan, but to the next generation. But we haven't yet been able to look at that question in a large population-based study. So what we did is we went back to the population of former evacuees and with the help of colleagues in Sweden, traced the hospital records of the offspring of the evacuees. And we said, well, what are rates of being hospitalized for a psychiatric disorder among the offspring as compared to the offspring of evacuees, as compared to the offspring of parents who were not in the evacuation program.
What did you find?
What we found is also a higher risk, and also among women. And what we found is that the female offspring of the evacuees were also at higher risk for being hospitalized for a psychiatric disorder, and also most strongly for a mood disorder.
Any indication why women might be more likely to be affected than men?
Well, that's a question that we've been grappling with. We can't address the mechanism in our study. We know that women are at higher risk for depression in general, and large population-based studies have shown that. Our results are consistent with that. There is also research that says that shows that some adverse exposures during childhood may also have stronger effects among women, but we don't know the answer. What we do know is that there's no simple explanation. So studies that have looked at, is it genetics, is it social environment during childhood, is it biological factors, there does not seem to be any one single answer that has yet been able to explain those differences.
How many records did your colleagues comb through? What size was your sample?
Upwards of 90,000. So in our earlier study of the evacuees and their non-evacuated siblings, there were about 45,000. Now that we're looking at the offspring, we studied over 90,000 offspring.
What do these findings suggest to you and to your colleagues?
They are concerning because they suggest that not only do adverse exposures or experiences during childhood impact mental health across one's life course, but that they may carry over to the next generation. And what was most striking to us when we thought about the interpretation of our findings is that the offspring, they were not exposed to the evacuation. Right? We assume that they might have heard about it from their parents or from the news, but they themselves were not directly exposed. Yet, for the women, they experienced a higher risk of a mental health problem, and that was what was most concerning to us.
On a broader scale, we still look at evacuees, people fleeing their homelands from a number of countries right now. What are the implications for a study like this?
Well, that's the question we've been asking ourselves too, is what are the implications of our World War II era findings for today? And one thing that I think is very important to appreciate about the Finnish experience is that this was a program designed to protect children. And essentially what we found is an unintended but long-term consequence of that. I think that has substantial ramifications for today and children exposed to armed conflict today, clearly not as a result of policies designed to protect them from any harms. And so it both reinforces that our policies intended for child protection should consider both risks and benefits or potential harms, but also examine very long-term potential effects.
Does it suggest the need for additional help for refugees, additional screening or mental health screening or supports for people that have been resettled?
I think that's a possibility. I think we can't directly test that question in our study, but there is very compelling evidence from other studies that have conducted interventions among either war-exposed youth or other children exposed to other types of adversities, that interventions can be beneficial and can, in part, redress or mitigate some of the long-term consequences.
If you're in a community where you have refugees, people who've been resettled, what are some things people can do to help? What are some takeaways for the community and for parents?
I think what our research demonstrates is that experiences today can have very long-term effects, and to focus not only on the short term, but to consider the potential for long-term effects many years afterwards. And so that our intervention programs that we might be considering may oftentimes be relatively short interventions. And perhaps one of the implications of our study is that it's necessary to consider both short-term as well as much longer-term environments and experiences of individuals exposed to different types of adversities.
If you could describe for me how you worked with your colleagues in Sweden.
My colleague, his name is Torsten Santavirta, and he's in Sweden. And he's been working with on the question of the Finnish evacuees for many years. And we've been collaborating since our earlier study. And because of the great data available in Finland, and he was able to access data from the former evacuees and link those data to hospital discharge records. And because it's known from the public, it's known from public records who the former evacuees were. That was a public program, and through data use agreements, was able to link those confidentially to hospital discharge records.
Tell me where you got your undergraduate, your graduate.
My undergraduate degree is from Tufts University in social psychology, and my graduate degrees are in health and social behavior from the Harvard School of Public Health.
PhD?
SCD, which is Doctor of Science.
How would you describe your social science, what you do?
Well, my interests are in social epidemiology, which is the branch of epidemiology that tries to understand social determinants of health, and also developmental epidemiology, so it merges those things because it's focused on trying to understand child development and the social determinants of health.